Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Acetaminophen, also known as paracetamol, was first identified in Germany in 1887. Initially, its use was limited due to concerns about its toxicity, leading to its rejection in favor of the related drug phenacetin. However, by the late 1940s, acetaminophen was reconsidered and recognized as a safer alternative to other medications. During the 1950s, it was marketed as an analgesic and fever reducer in the United States under the brand name Tylenol, and in the United Kingdom as Panadol. By the late 1800s, both phenacetin and acetanilide were used as pain relievers and fever reducers. However, their application was limited due to significant side effects, notably methemoglobinemia. The major metabolite responsible for the analgesic and antipyretic effects of these drugs, N-acetaminophenol, was synthesized in 1878. It was found to pose a lower risk of causing methemoglobinemia. This compound is commonly known as acetaminophen in North America and Japan, and as paracetamol in other regions. In the mid-1950s, acetaminophen was first used in clinical settings in the United States and the United Kingdom. Nonetheless, widespread acceptance was delayed until the 1970s because of concerns about its potential toxicity inherited from its predecessor drugs. Once it was demonstrated that acetaminophen was safe when used at appropriate doses, its popularity rapidly increased. This prompted the development of numerous formulations, including single and combination products with various delivery systems. It was only around 1966, approximately a decade after its introduction, that the toxicity associated with overdosing on acetaminophen was recognized. The first cases of toxicity were reported in Scotland. Initially, there were no effective treatments, leading to a rise in severe illness and death due to overdose. In the 1970s, extensive research by Laurie Prescott and colleagues at the Royal Infirmary in Edinburgh greatly advanced understanding of acetaminophen toxicity. Their work established a relationship between plasma concentrations of the drug and the risk of liver damage. Animal studies provided insights into the mechanisms of toxicity and potential antidotes. Follow-up studies in the United Kingdom and North America tested the effectiveness of treatments such as cysteamine methionine and N-acetylcysteine. By the late 1970s, evidence from the United Kingdom confirmed that N-acetylcysteine was the preferred antidote. Despite these developments, deaths related to acetaminophen overdose did not decline significantly. In response, the United Kingdom imposed restrictions on over-the-counter pack sizes in 1998 to reduce mortality. Today, acetaminophen remains a widely used medication. However, its availability without a prescription contributes to frequent misuse and overdose, making it a leading cause of acute liver failure. Ongoing challenges include accidental overdoses due to confusion over product labeling and the varying amounts of acetaminophen in different medications. The development of modified release and intravenous formulations has further complicated overdose management. These learning objectives offer a comprehensive framework for understanding acetaminophen toxicity. They cover the drug's history, metabolism, toxic effects, diagnostic methods, and various treatment options. It is important to remember that ongoing research and advancements in medical practices necessitate continuous learning and updating knowledge in this field. To begin, it is essential to understand the history of acetaminophen, including its delayed acceptance and eventual rise in popularity. The metabolism of acetaminophen involves the formation of a toxic metabolite called N-acetylpbenzoquinone imine. Several factors can influence the toxicity of acetaminophen, such as the induction of certain liver enzymes, depletion of glutathione, and the concurrent use of opiates. Diagnosis of acetaminophen toxicity relies on specific criteria, including the use of the Rumack-Matthew nomogram and measurement of serum acetaminophen concentration. However, the nomogram has limitations, particularly in cases involving extended-release formulations, intravenous administration, or chronic overdoses. Managing massive overdoses presents additional challenges due to altered pharmacokinetics and the potential for toxicity outside the liver. The product of the acetaminophen concentration and the time since overdose can serve as a predictor of liver damage. Interestingly, there is an inverse relationship between serum acetaminophen levels and the likelihood of allergic-like reactions to N-acetylcysteine, a common antidote. The King's College criteria assist in deciding when liver transplantation may be necessary in severe cases. N-acetylcysteine operates through multiple mechanisms to treat toxicity, and various regimens exist, including standard European protocols, the SNAP regimen, simplified 2-rate protocols, and North Carolina protocols. The duration of treatment and criteria for stopping therapy depend on specific patient factors. Moreover, N-acetylcysteine can be effective in treating other poisonings, such as those caused by certain mushrooms containing cyclopeptides. Emerging therapies such as fomepizole show promise in managing acetaminophen poisoning. Additionally, alternative treatment approaches, including enhanced elimination techniques and experimental therapies, are being explored to improve outcomes in overdose cases. Acetaminophen is metabolized in the liver primarily through 3 pathways. The predominant pathway is glucuronidation, which accounts for over 50% of acetaminophen clearance. This process involves attaching glucuronic acid to acetaminophen, resulting in a water-soluble compound that can be easily excreted in the urine. The second most common pathway is sulfation, contributing to approximately 40% of acetaminophen metabolism. Sulfation involves adding a sulfate group to acetaminophen, creating another water-soluble compound for elimination. A smaller portion of acetaminophen, about 4% at therapeutic doses, undergoes oxidation via the cytochrome P450 enzyme system, mainly by CYP2E1 and to a lesser extent by CYP1A2. This pathway leads to the production of N-acetylpbenzoquinone, NAPQI, a toxic metabolite. Most acetaminophen is metabolized primarily through glucuronidation and sulfation at therapeutic doses, resulting in non-toxic metabolites. A small amount of NAPQI is produced in this process, and it is effectively detoxified by glutathione. However, when acetaminophen intake exceeds the liver's capacity to detoxify NAPQI, the toxic metabolite accumulates and can cause liver damage. Several factors influence the balance between these metabolic pathways and can contribute to acetaminophen toxicity. Compounds that induce CYP2E1, such as ethanol, rifampicin, isoniazid, and carbamazepine, can increase the production of NAPQI, thereby raising the risk of toxicity. Chronic use of drugs that induce CYP2E1 or smoking tobacco may lead to poorer outcomes following an overdose of acetaminophen. Co-ingestion of opiates can also enhance the toxic effects of acetaminophen. Individuals with depleted glutathione stores, such as those suffering from malnutrition or chronic alcoholism, are at higher risk of toxicity. Additionally, conditions like myopathies and acute starvation may increase susceptibility to toxicity from an overdose. Understanding the metabolic pathways of acetaminophen and the factors that influence the production and detoxification of its toxic metabolite, NAPQI, is essential for the safe and effective use of this common medication. Acetaminophen overdose can cause mitochondrial injury as part of the overall hepatic damage. Research has indicated that agents capable of preventing mitochondrial injury can diminish liver damage induced by acetaminophen in animal models. When the liver metabolizes acetaminophen through CYP2E1, it produces a toxic metabolite known as NAPK. If glutathione does not neutralize NAPK, this compound binds to the membranes of hepatic cells, including the mitochondrial membrane. Such binding disrupts the lipid bilayer and hampers mitochondrial function. Studies have shown that both acetaminophen and NAPK can directly inhibit mitochondrial respiration. This occurs at the level of ubiquinone, a crucial component of the electron transport chain responsible for ADP generation. As a result, cellular energy production declines, which contributes to cell death. The inhibition of mitochondrial respiration may lead to metabolic acidosis and increased lactate levels, especially in overdose cases. When mitochondrial function is compromised, cells shift to anaerobic metabolism to produce energy, leading to elevated lactate. This early acidosis often resolves on its own within hours, but if the patient's condition worsens, the acidosis may recur and serve as a strong indicator of potential mortality. Glutathione plays a vital role in protecting mitochondria from oxidative stress. During an overdose, glutathione stores become depleted, which leaves mitochondria vulnerable to damage by reactive oxygen species (ROS). This further impairs mitochondrial function and promotes cell death. Acetaminophen is generally safe when taken at appropriate dosages. However, it has a narrow therapeutic index. Factors that increase the production of NAPK or impair the body's ability to detoxify, it can lead to toxicity. NAPK is produced when CYP2E1 metabolizes acetaminophen, and substances that induce CYP2E1, such as ethanol, rifampicin isoniazid, and carbamazepine, can increase NAPK levels, thereby elevating the risk of toxicity. Chronic use of drugs that induce CYP2E1 or smoking can also worsen outcomes following an overdose. Glutathione plays a crucial role in detoxifying NAPK. Its depletion due to malnutrition or chronic alcoholism raises the risk of toxicity. Co-ingestion of opiates may enhance the toxic effects of acetaminophen. Age influences susceptibility. Young children often exhibit greater resistance, possibly because of a larger liver volume relative to body size, while older adults face increased hepatotoxicity risk. Other medical conditions, such as myopathies and acute starvation, like that experienced during severe dental pain, can heighten toxicity risk. Both the dose and the duration of acetaminophen use are important considerations. Even doses within the recommended daily limits can cause liver damage if taken excessively. Chronic therapeutic use might slightly elevate ALT levels, although the clinical significance of this remains debated. Individual genetic variability also affects toxicity risk, with some people capable of detoxifying NAPK more efficiently or producing less of it, allowing for safe chronic use of large amounts. Formulations of acetaminophen can complicate risk assessment and overdose management. Modified release products delay absorption, which may impact the accuracy of standard nomograms used to predict toxicity. Interestingly, while acute ethanol co-ingestion might seem to increase toxicity risk initially, it can actually have a protective effect by inhibiting CYP2E1 activity and competing for metabolism. Nonetheless, chronic alcohol consumption depletes glutathione stores, increasing susceptibility to toxicity from subsequent acetaminophen intake. Additionally, propylene glycol, found in pediatric elixirs, can inhibit CYP2E1 and has been shown to prevent hepatotoxicity in mice, potentially contributing to the lower incidence of liver injury observed in children. The diagnostic criteria for acetaminophen toxicity vary depending on the nature of the exposure, whether it was an acute single ingestion or repeated supratherapeutic ingestions. Defining a single toxic dose is challenging because individual susceptibility is influenced by many factors. Therefore, the focus is placed on understanding the circumstances and factors that can make acetaminophen use potentially dangerous rather than establishing a universal toxic dose. In cases of acute overdose, obtaining a thorough history is crucial to determine both the timing and the quantity of acetaminophen ingested. This information helps assess the initial risk. Generally, in adults without risk factors, doses below 150 milligrams per kilogram are unlikely to cause severe liver damage. Children under 6 years old tend to be more resistant to toxicity. Studies suggest that a single ingestion of 200 milligrams per kilogram or less in this age group is unlikely to result in significant toxicity. However, these values should not be interpreted as safe doses, as individual variations, and the lack of a universally toxic dose highlight the importance of careful monitoring and early medical intervention in any suspected overdose. Measuring the serum acetaminophen concentration is central to diagnosing an acute overdose. The concentration should be obtained at least 4 hours after ingestion to ensure complete absorption. This value is then plotted on the Rumac methanogram. If the concentration exceeds the treatment line, the patient is at risk of hepatotoxicity and requires treatment with N-acetylcysteine NAC. Conversely, if the level remains below the treatment line, the risk is generally low and NAC treatment is usually unnecessary. Additionally, an aspartate aminotransferase AST test is recommended for patients with potential risk factors based on their history or if they exhibit signs or symptoms of hepatotoxicity. Diagnosing toxicity following chronic acetaminophen exposure poses greater challenges because the standard nomogram is not applicable. In such cases, the focus shifts to a thorough history-taking and physical examination. Careful assessment for signs and symptoms of hepatotoxicity is essential, including right upper quadrant abdominal pain, jaundice, and vomiting. Regardless of the patient's dosage history, these findings should prompt immediate administration of N-acetylcysteine NAC and further laboratory evaluation. When evaluating risk, it is important to consider the total daily dose and duration of supratherapeutic acetaminophen use. Certain risk factors increase the likelihood of toxicity, such as chronic heavy alcohol consumption, prolonged use of isoniazid, febrile illnesses in infants and young children, and malnutrition. The generally recommended daily dose for adults is 4 grams. Exceeding this amount for a day or longer raises the risk of hepatotoxicity. For children, the maximum recommended daily dose is 75 milligrams per kilogram of body weight. While there have been reports of hepatotoxicity at lower doses, there remains some uncertainty regarding the accuracy of these reports. Laboratory evaluation should include measuring acetaminophen concentration and AST levels in asymptomatic patients with relevant risk histories. If AST levels are elevated, regardless of the acetaminophen concentration, the patient is considered at risk and should receive NAC therapy. Even if AST levels are normal but the acetaminophen level is detectable at 10 micrograms per milliliter or higher, the patient may still require NAC. Additional laboratory tests such as creatinine prothrombin, PT, INR, pH phosphate, and lactate may be necessary to assess the extent of hepatotoxicity and determine prognosis, particularly in patients with significantly elevated AST levels following chronic use. When the time of ingestion cannot be determined, the following approach should be taken. If the aspartate aminotransferase AST level is elevated, treat with N-acetylcysteine NAC. If the acetaminophen concentration is detectable, assume there is a risk and initiate NAC. However, if both AST and acetaminophen are undetectable, the risk is considered low. The diagnostic approach for pregnant women is similar to that for non-pregnant patients. No adjustments to the treatment guidelines on the nomogram are necessary. Nevertheless, a careful assessment of the potential risks and benefits is essential when deciding to treat pregnant women with NAC. In cases where hepatotoxicity is suspected but the ingestion history is unclear, it is important to consider acetaminophen as a possible cause, even if the acetaminophen concentration is undetectable. Other common causes of liver injury should also be investigated. The effect of ethanol consumption on acetaminophen toxicity is complex and depends on various factors, including the timing and amount of alcohol intake. Acute ethanol co-ingestion may have a hepatoprotective effect, whereas chronic heavy ethanol use can increase the risk of toxicity from repeated intake of supertherapeutic doses of acetaminophen. There are limitations to existing diagnostic tools. The Rumack-Matthew nomogram, for example, is designed specifically for acute, single ingestions and may not accurately predict the risk in cases involving extended-release formulations, intravenous administration, or chronic overdoses. Relying solely on the AST level to diagnose repeated supertherapeutic ingestions may not be sensitive enough to detect early liver injury. Additionally, the availability of rapid and reliable biomarkers for assessing the risk of hepatotoxicity in ambiguous scenarios is limited. Understanding the complexities of acetaminophen toxicity is essential. It requires a combination of taking a thorough history, clinical findings, and laboratory tests to effectively guide diagnosis and treatment. The Rumack-Matthew nomogram is used to assess the risk of hepatotoxicity caused by acetaminophen following a single acute ingestion. It works by plotting the initial serum acetaminophen concentration against the time elapsed since ingestion. A key feature of this nomogram is the treatment line, also known as the 150 line, which extends from a concentration of 150 micrograms per milliliter at 4 hours to 4.7 micrograms per milliliter at 24 hours. If a patient's serum acetaminophen level is above this line, it indicates a significant risk of liver damage and warrants treatment with N-acetylcysteine NAC. The development of a nomogram was based on early observations of untreated patients. Researchers distinguished those who developed elevated aspartate aminotransferase AST levels above 1,000 IU/L from those who did not, using their initial acetaminophen concentrations. Over time, the initial discriminatory line was lowered to increase its sensitivity. Importantly, the nomogram is designed to use a single acetaminophen concentration measured at or after 4 hours post-ingestion, ensuring the drug has been fully absorbed. While patients experiencing hepatotoxicity often have half-lives exceeding 4 hours, the practice of plotting multiple data points or employing half-life calculations for risk assessment has not been well studied. The slope of a nomogram is derived empirically from clinical data and does not directly represent a specific kinetic model or half-life. Internationally, there are variations in the application of the nomogram. In the United States, the 150 line is standard, offering high sensitivity with a failure rate between 1% and 3%. In contrast, the United Kingdom uses a more conservative 100 line for all cases of acute acetaminophen ingestion. This approach is preferred due to concerns about hepatotoxicity in patients whose serum concentrations fall between the 100 and 200 micrograms per milliliter range. Several factors can influence the accuracy and interpretation of the acetaminophen nomogram. Accurate ingestion history is crucial, as the nomogram depends on a precise timing of ingestion. When the exact time is unknown, the earliest possible time is used to determine risk, which creates a worst-case scenario. Extended-release formulations of acetaminophen present challenges due to delayed absorption. This can cause an initial concentration below the treatment line, followed by a rise above the line, a phenomenon known as nomogram crossing. While not exclusive to extended-release products, this highlights the importance of careful monitoring and possibly implementing alternative treatment protocols. The nomogram has not been validated for intravenous acetaminophen overdose. Intravenous administration results in higher initial concentrations and greater bioavailability compared to oral intake, yet both routes can produce similar 4-hour concentrations. Cases of hepatotoxicity have occurred with intravenous acetaminophen, even when levels were below the treatment threshold indicated by the nomogram. Although rare, chronic use of isoniazid may predispose patients to acetaminophen toxicity, which could necessitate adjustments to the standard nomogram. It is crucial to strictly adhere to the acetaminophen nomogram when evaluating the risk following an acute overdose. Plotting the earliest possible time of ingestion helps maintain a conservative approach to assessing risk. Generally, an acetaminophen concentration below the treatment line indicates a low likelihood of toxicity, thereby eliminating the need for N-acetylcysteine and AC therapy. However, there have been reports of hepatotoxicity, even at concentrations below the line, emphasizing the importance of considering individual patient factors, the accuracy of ingestion history, and possible drug interactions. When making decisions about NAC treatment, the primary objective is to obtain an accurate acetaminophen concentration as soon as possible, ideally 4 hours after ingestion, to facilitate informed decision-making. Initiating NAC promptly after confirming a risk is optimal. If started within 8 hours of ingestion, it has nearly 100% efficacy. In cases where acetaminophen levels are unavailable before 8 hours, NAC treatment should be initiated and later adjusted based on the measured concentration and nomogram interpretation. The Rumac-Matthew nomogram has proven to be a valuable tool in managing acute acetaminophen overdose. Nonetheless, its limitations and potential confounding factors require careful interpretation, accurate ingestion histories, and consideration of specific patient characteristics. Continued research is essential for developing validated protocols, especially for extended release and intravenous formulations of acetaminophen, to ensure the best possible patient outcomes. Massive acetaminophen overdose presents unique challenges and may require modified treatment approaches compared to less severe exposures. However, there is no universally accepted definition of what constitutes a massive overdose. Several factors have been proposed to distinguish such cases from less severe ones. One factor is the total amount ingested, with studies using thresholds ranging from over 30 grams to over 50 grams, regardless of co-ingestants, to define a massive overdose. Another criterion is the weight-based amount, where proposals include using double the accepted toxic dose of 300 milligrams per kilogram, 500 milligrams per kilogram, or even 1g/kg as indicators of massive ingestion. Serum concentrations measured at 4 hours post-ingestion have also been considered, with thresholds of greater than 250 micrograms per milliliter, 300 micrograms per milliliter, and 500 micrograms per milliliter suggested as markers. Each of these definitions has been associated with a higher likelihood of severe outcomes. Nevertheless, a definitive standard remains elusive. It is generally recommended to consider any overdose meeting one or more of these criteria as potentially massive. Managing massive overdoses poses additional challenges. The pharmacokinetics of acetaminophen can be altered in such cases, affecting absorption, distribution, metabolism, and elimination processes. Besides liver damage, massive overdoses can lead to complications such as acute kidney injury, metabolic acidosis, central nervous system depression, methemoglobinemia, and hemolysis. Regarding treatment, the standard dose of N-acetylcysteine NAC at 300 milligrams per kilogram may not be sufficient to replenish depleted glutathione stores in massive overdoses. This has sparked debate about whether higher doses are necessary to improve outcomes. NAC administration remains the cornerstone of treatment, although the most effective regimen for massive overdoses is not clearly established. Several options are available, including a high-dose modified European regimen that involves a 150 milligrams per kilogram loading dose followed by a continuous infusion of 12.5 milligrams per kilogram per hour. Another alternative is the SNAP regimen, which consists of a 50 milligrams per kilogram per hour infusion for 2 hours, then a continuous infusion of 20 milligrams per kilogram per hour. The modified Australian regimen doubles the maintenance rate, administering 50 milligrams per kilogram per hour for 4 hours before switching to a 12.5 milligrams per kilogram per hour infusion. Additionally, the North Carolina 2-rate regimen uses a 150 milligrams per kilogram loading dose followed by a 15 milligrams per kilogram per hour continuous infusion. Further details on these regimens will be discussed below. In cases of overdose, gastrointestinal decontamination with activated charcoal or gastric lavage may be considered, particularly in consultation with a toxicologist. These methods are not routinely recommended but can be useful depending on the timing and severity of overdose. Regarding renal replacement therapy, both hemodialysis and continuous renal replacement therapy (CRRT) can be life-saving. They are effective in removing acetaminophen from the bloodstream and in correcting electrolyte imbalances and acid-base disturbances in cases of massive overdose. Fomepizole, an inhibitor of CYP2E1, shows promise as an adjunctive therapy. It may help prevent or reduce liver damage when administered early. Severe cases should be promptly transferred to specialized liver centers where interventions such as transplantation can be considered if necessary. A significant challenge in managing acetaminophen overdose is the lack of consensus on severity classification. While there are difficulties in defining and categorizing massive overdoses, the spectrum of milder and moderate overdoses is not well standardized. This absence of a unified classification system hampers the ability to compare cases and tailor treatments effectively. Further research is needed to develop a comprehensive and widely accepted system for categorizing overdose severity and guiding clinical management. The acetaminophen at multiplication product is a clinical tool used to evaluate the risk of hepatotoxicity in patients who have overdosed on acetaminophen. It was developed based on data from the Canadian Acetaminophen Overdose Study (CAOS), which involved patients hospitalized for a single acute acetaminophen overdose with hepatotoxicity between 1980 and 2005. The calculation of this product involves multiplying the initial serum acetaminophen concentration, measured in mg/ml, by the peak serum aminotransferase level, such as AST or ALT, recorded in units per liter within the first 24 hours of presentation. A product value exceeding 10,000 mole units/L superscript 2 or 1,500 mg/ml units/L indicates a high likelihood of hepatotoxicity. Validation studies have demonstrated that this threshold offers high sensitivity at lower levels and high specificity at higher levels. This tool is highly predictive of hepatotoxicity in patients with acetaminophen poisoning, even among those who present late after ingestion. It effectively considers both the amount of acetaminophen ingested reflected in serum concentration and the extent of liver injury indicated by aminotransferase levels. There are several advantages to using the acetaminophen at multiplication product. It is simple to use, requiring only standard laboratory tests such as an acetaminophen level and an AST or ALT measurement, which are readily available in most healthcare settings. It allows for early assessment, enabling timely intervention with NAC therapy soon after presentation. Additionally, it is versatile and can be employed in various scenarios, including cases where the ingestion time is unknown, situations involving repeated supratherapeutic ingestion, and retrospective studies. However, the tool has limitations. Its applicability diminishes in delayed presentations, particularly beyond 24 hours after ingestion, because it relies on the initial serum acetaminophen concentration and peak aminotransferase levels within that period. It should not replace clinical judgment. Instead, it serves as an adjunct to comprehensive clinical assessment. Physicians should interpret the product alongside the patient's history, symptoms, and other laboratory findings. Overall, the acetaminophen at multiplication product is a valuable aid for predicting hepatotoxicity in acetaminophen poisoning. Its ease of use, early applicability, and versatility enhance its usefulness. Nonetheless, understanding its limitations and combining it with other clinical information is essential for guiding treatment decisions effectively. Several novel biomarkers are currently under investigation for their potential to enhance prognosis prediction in acetaminophen poisoning. These biomarkers offer various benefits. For instance, markers such as microRNA 122, HMGB1, K18, and GLDH tend to be significantly elevated in patients who initially present with normal ALT levels but later develop liver injury. Detecting these changes early can facilitate quicker intervention, potentially leading to better outcomes. Additionally, certain biomarkers, like the acetaminophen at multiplication product, demonstrate high sensitivity at low thresholds and high specificity at elevated thresholds. This improves risk stratification by better identifying patients at both low and high risk of hepatotoxicity, thus guiding treatment decisions more effectively. Furthermore, markers indicative of hepatic synthetic function, such as hypoglycemia, lactic acidosis, and prothrombin, can provide valuable insights into the liver's functional capacity. These markers are often better predictors of mortality or the need for a transplant than traditional criteria like the King's College criteria. However, there are limitations to the clinical application of these novel biomarkers. Many are still in the research phase and require further validation through extensive studies to determine optimal cutoff points and ensure consistent results across diverse patient populations. Cost and accessibility also pose challenges as some biomarkers, including acetaminophen protein adducts and metabolomics analyses, necessitate specialized laboratory equipment and techniques, making them potentially expensive and less available in certain healthcare settings. While promising, many of these biomarkers have yet to reach routine clinical use due to difficulties in conducting ethical toxicology studies in humans and the need for additional research to establish their true utility. Additionally, the interpretation of some biomarkers, such as metabolomics data, can be complex and require sophisticated data processing, which may limit their practicality in time-sensitive clinical scenarios. Despite these challenges, traditional markers like liver function tests and the Rumack-Matthew nomogram remain valuable tools. Nevertheless, these emerging biomarkers offer significant promise for improving the accuracy and timeliness of prognosis in acetaminophen poisoning. The King's College criteria, KCC, are a set of clinical and laboratory parameters used to assess the prognosis of patients with acetaminophen-induced fulminant hepatic failure and to determine the necessity of liver transplantation. The criteria originated from data collected between 1973 and 1985 at King's College Hospital in London, involving 310 patients with acetaminophen-induced liver failure. They were later validated in a subsequent study with 120 patients treated between 1990 and 1994. The KCC demonstrate a high positive predictive value of 88% for death without transplantation. However, their negative predictive value is lower at 65%, indicating that many patients who do not meet the criteria still require transplantation. Since the establishment of the KCC, survival rates for patients with acetaminophen-induced liver failure have increased, likely due to advancements in supportive care and prolonged NAC therapy. The original KCC includes either an arterial pH less than 7.25 at 24 hours or later after overdose despite fluid resuscitation, and sodium bicarbonate administration, reflecting severe metabolic acidosis and significant liver dysfunction. Additionally, the criteria consider the presence of all three of the following: grade 3 or 4 encephalopathy, indicating advanced brain dysfunction due to toxin buildup, a serum creatinine level higher than 3.4 milligrams per deciliter 300 mol/L, signifying impaired kidney function, and an international normalized ratio, INR, longer than 6.5, reflecting severe coagulopathy due to impaired liver synthesis. In the UK, updated criteria are used for emergency liver transplantation in cases of acetaminophen poisoning. These include a pH below 7.25 despite fluid resuscitation, severe coagulopathy with INR over 6.5 combined with renal failure, such as anuria or serum creatinine exceeding 300 mol/L, and grade 3 to 4 encephalopathy. Additional criteria involve serum lactate levels greater than 3.5 millimoles per liter at admission or over 3.0 millimoles per liter after fluid resuscitation. The presence of any two criteria from this category, along with clinical deterioration absent of sepsis, also warrants consideration. It is important to recognize that the KCC are not static markers and should be assessed dynamically as the patient's condition evolves. Interpretation can be influenced by factors such as administration of NAC, which can affect INR measurements, and the use of clotting factors, which may temporarily improve PT/INR without reflecting true liver function. Other prognostic tools, such as the Model for End-Stage Liver Disease, MELD score, and the Acute Liver Failure Group Index, are also employed to evaluate severity and guide transplantation decisions. However, the KCC often become positive later in the course of liver failure, limiting their usefulness as early predictors for transplantation or transfer to specialized centers. In summary, the KCC are valuable for identifying patients at high risk of mortality from acetaminophen-induced liver failure who may benefit from transplantation. Their interpretation should always consider the patient's overall clinical presentation and other prognostic indicators. Early consultation with a liver transplantation center is essential for patients with severe acetaminophen toxicity to ensure timely assessment and management. NAC is the primary treatment for acetaminophen toxicity when administered promptly, serving as a highly effective antidote. Its mechanisms of action involve several key processes. First, NAC prevents the formation of the toxic metabolite NAPK during acetaminophen metabolism. Additionally, it enhances NAPK detoxification by acting as a precursor to glutathione, a natural antioxidant that conjugates with and neutralizes NAPK. NAC can also directly bind to NAPK, substituting for glutathione. In cases of fulminant hepatic failure, NAC helps protect multi-organ function by replenishing depleted glutathione stores, acting as a direct antioxidant to scavenge reactive oxygen species, and improving microvascular function and blood flow. Administration of NAC can be done orally or intravenously. Traditionally, fixed-duration protocols, such as a 21-hour intravenous infusion or a 72-hour oral dosing regimen, were common. However, many current approaches favor tailoring the duration of therapy to the individual patient's clinical course and risk assessment. Therapy should be initiated as soon as the patient is identified to be at risk of toxicity based on established diagnostic criteria. Continued treatment is necessary as long as there is ongoing risk or signs of hepatotoxicity. The decision to discontinue NAC depends on the patient's clinical condition and laboratory results, aiming to ensure that the risk of toxicity has passed and any liver damage has resolved. Specific recommendations for discontinuing NAC vary depending on the patient's condition. For patients with hepatic failure, intravenous NAC should be continued until their prothrombin time, PT, or international normalized ratio, INR, falls below twice the normal value, encephalopathy resolves if present, and the serum acetaminophen concentration becomes undetectable. In cases where patients do not have hepatic failure but exhibit elevated AST levels, NAC should be continued until the AST levels are decreasing and drop below 1000 IU/L. Additionally, the AST to ALT ratio should be less than 0.4, and there should be no evidence of liver failure. The serum acetaminophen concentration also plays a role in determining the appropriate time to discontinue NAC. While most patients receive the standard intravenous dosing of N-acetylcysteine NAC, which involves a loading dose followed by a continuous infusion, many practitioners in toxicology recognize that higher doses may be necessary in certain situations. For example, in cases of massive ingestions where patients consume more than 30 grams of acetaminophen, there may be a need for increased NAC doses due to the potential for prolonged absorption and exposure. Additionally, some patients show a delayed rise in serum acetaminophen levels despite initial treatment with NAC. This late increase might require administering higher doses to ensure sufficient antidote coverage. There are also other treatment considerations. Gastric decontamination with activated charcoal can be effective if given within 1 hour of ingestion, although gastric emptying is generally not recommended because of acetaminophen's rapid absorption and the effectiveness of NAC. Supportive care plays a critical role in managing complications arising from hepatotoxicity, acute kidney injury, and other organ dysfunctions. This includes monitoring and treating hypoglycemia, administering vitamin K, and clotting factors based on specific indications rather than solely relying on PT/INR values, and implementing therapies to manage cerebral edema. The treatment of acetaminophen toxicity continues to face challenges. One significant issue is the lack of reliable biomarkers to identify patients at risk, especially in cases where the ingestion history is uncertain or there is a chronic overdose. Ongoing research aims to find novel biomarkers to improve risk assessment. Another challenge involves adverse reactions to NAC, such as anaphylactoid responses, which are more common with intravenous administration. Efforts are also underway to optimize NAC protocols, including refining dosing strategies, administration routes, and treatment durations to enhance efficacy while minimizing adverse effects. NAC is a highly effective antidote for acetaminophen overdose, functioning through multiple mechanisms to counteract the toxic effects of acetaminophen and its harmful metabolite, NAPQI. Its primary role involves replenishing and substituting glutathione, a vital antioxidant essential in detoxifying NAPQI. Normally, acetaminophen is metabolized in the liver primarily via sulfation and glucuronidation into non-toxic metabolites. However, a small portion undergoes conversion by the cytochrome P450 enzyme system, mainly CYP2E1, into NAPQI, which is highly reactive and toxic. Glutathione acts as a scavenger, binding to NAPQI and neutralizing it, forming a non-toxic complex that is subsequently metabolized and expelled from the body. In overdose situations, the excessive production of NAPQI depletes the liver's glutathione reserves, leading to the accumulation of NAPQI and resulting cellular damage. NAC intervenes effectively by serving both as a precursor and a substitute for glutathione. As a precursor, NAC supplies cysteine, a key amino acid necessary for glutathione synthesis, thereby directly restoring depleted glutathione levels. It also acts as a substitute by directly binding to NAPQI, similar to glutathione, and forming harmless mercaptan conjugates that are then eliminated from the body. NAC also indirectly reduces the formation of NAPQI by enhancing the sulfation pathway of acetaminophen metabolism. Acetaminophen is primarily metabolized through three main pathways: sulfation, glucuronidation, and oxidation. The sulfation and glucuronidation pathways produce non-toxic metabolites, whereas the oxidation pathway, mediated by CYP2E1, generates NAPQI. By supplying cysteine as a substrate for sulfation, NAC effectively shifts the metabolic balance of acetaminophen towards the non-toxic sulfation pathway. This shift decreases the amount of acetaminophen processed via the oxidation pathway, thereby reducing the production of NAPQI. In cases of severe acetaminophen overdose leading to fulminant hepatic failure, NAC exhibits additional beneficial effects beyond its primary role in detoxifying NAPQI. Although these effects are not fully understood, it is believed they involve reversing NAPQI oxidation, potentially through direct interaction with NAPQI or its protein adducts. Furthermore, NAC may improve microcirculatory blood flow and oxygen transport, which can help protect various organs from the consequences of systemic failure. A prospective randomized trial demonstrated that intravenous NAC administration, even after the onset of fulminant hepatic failure, significantly reduced the need for vasopressors, cerebral edema, and mortality. Importantly, the first two mechanisms, glutathione replenishment/substitution and sulfation enhancement, are most effective when NAC is administered early before NAPQI has caused substantial cellular damage. The third mechanism, though less fully understood, shows NAC's potential to mitigate systemic complications of liver failure, even in later stages. There are common adverse effects associated with both oral and intravenous administration of N-acetylcysteine NAC. When taken orally, the most frequent adverse effect is vomiting, which can occur in up to 20% of patients. This is likely due to the drug's unpleasant sulfur-like rotten egg odor and gastrointestinal upset commonly seen after acetaminophen overdose. One study reported that 51% of 515 patients with acetaminophen overdose experienced vomiting while receiving oral NAC. Administering NAC via an enteral tube in patients with a protected airway can help minimize nausea caused by the odor. If vomiting persists, antiemetics may be useful. Other adverse effects linked to oral NAC include nausea, flatus, diarrhea, gastroesophageal reflux, dysgeusia, altered taste, allergic skin reactions, and rarely angioedema. Intravenous NAC is associated with a higher rate of adverse reactions compared to oral administration. Anaphylactoid reactions occur in approximately 14 to 18% of patients. Most of these reactions are mild, around 6%, or moderate, about 10%, and involve skin reactions, nausea, and vomiting. Severe reactions such as bronchospasm, hypotension, and angioedema are rare, estimated at around 1%. These rates are based on the earlier formulation of NAC, known as Mucomyst, which, although sterile, was not intended for intravenous use. This is often cited as a reason why roughly 20% of patients experienced anaphylactoid reactions. A newer formulation, acetaminophen, specifically designed and packaged for intravenous use, has a significantly lower rate of reactions, closer to 8%, with only about 2% being clinically relevant. The risk of anaphylactoid reactions with intravenous NAC can be reduced by using a more dilute solution and slowing the infusion rate. These reactions are thought to be caused by non-Ig-mediated histamine release from mast cells and monocytes. Interestingly, acetaminophen inhibits mast cell histamine release, and higher concentrations of acetaminophen during NAC administration may decrease the risk of such reactions. Additional adverse effects associated with intravenous NAC include flushing, rash, pruritus, chest pain, cough, bronchospasm, headache, dizziness, convulsions, decreased prothrombin time in patients without liver impairment, and an increased international normalized ratio, INR, attributed to NAC's inhibition of factor VII. Rare, but severe reactions have also been reported, including hemolysis, hemolytic uremic syndrome, cerebral edema, and seizures. While both oral and intravenous NAC can cause adverse effects, most reactions are mild and manageable, with severe reactions being uncommon. An interesting observation across studies is the inverse relationship between serum acetaminophen concentration and the incidence of NAC-induced anaphylactoid reactions. As the serum concentration of acetaminophen increases, the likelihood of reactions decreases. Although the precise mechanism is not fully understood, this phenomenon has significant clinical implications. It supports the rationale for modified NAC regimens, such as the SNAP protocol, which employs a slower infusion rate to achieve lower peak serum concentrations and thereby minimize the risk of reactions. Understanding this inverse relationship is important for clinicians managing acetaminophen poisoning. It can influence decisions regarding NAC administration strategies and help anticipate potential adverse effects. While NAC is highly effective when administered within 8 hours of an acetaminophen overdose, its efficacy diminishes with each passing hour afterward. The relationship between the timing of NAC administration and the risk of hepatotoxicity is not characterized by a simple cutoff point. Instead, the risk begins to increase around 6 hours for patients whose acetaminophen levels exceed 600 micrograms per milliliter and approaches 8 hours for those just above the treatment threshold. Delaying NAC treatment beyond 8 hours significantly raises the likelihood of hepatotoxicity. Its effectiveness is limited in cases involving repeated supratherapeutic doses of acetaminophen, often because it is administered too late to be beneficial. Additionally, the nomogram used to predict the risk of hepatotoxicity based on acetaminophen levels at 4 hours becomes less reliable after 15 hours. Therefore, even though NAC remains the standard care for acetaminophen overdose, early administration is essential to maximize its protective effects. Managing acetaminophen toxicity after 8 hours requires a thorough history and clinical assessment. When a patient presents more than 8 hours after ingestion, it is crucial to gather detailed information, including the estimated dose ingested. If the exact time of ingestion is unknown but elevated AST levels are observed, treatment with NAC should be initiated. In cases where the time of ingestion is uncertain or exceeds 8 hours but the history suggests a potentially toxic dose, consider administering NAC while awaiting blood test results. Monitoring liver function tests such as AST, ALT, and INR, along with renal function, is essential since delayed presentations may still lead to hepatotoxicity. If liver failure develops, continue NAC therapy until the prothrombin time/international normalized ratio, PT/INR, is less than twice the normal value and any encephalopathy has resolved. The optimal methods and dosages for administering NAC depend on various factors, including the indication for use and the individual characteristics of the patient. In cases of acute acetaminophen poisoning, both oral and intravenous NAC offer essentially the same efficacy, although each route presents its own advantages and disadvantages. The choice between them should consider the risks of adverse events, safety considerations, availability, and ease of administration. Intravenous NAC is associated with a 14 to 18% rate of anaphylactoid reactions, though retrospective studies report rates between 2 to 6%. Most of these reactions are mild and may include symptoms such as rash, flushing, nausea, and vomiting. Severe reactions occur in about 1% of cases, and in rare instances, can lead to hypotension or death. Using a more dilute solution and slowing the infusion rate can reduce the risk of anaphylactoid reactions. Conversely, oral NAC has a 20% incidence of nausea and vomiting. Delays in administering NAC increase the risk of hepatotoxicity, making prompt treatment critical. However, oral NAC can be difficult to administer to patients with altered mental status due to the risk of aspiration. Specific indications for intravenous NAC include fulminant hepatic failure, inability to tolerate oral NAC, and acetaminophen poisoning during pregnancy. The traditional U.S. oral dosing regimen involves a loading dose of 140 milligrams per kilogram, followed by 70 milligrams per kilogram every 4 hours for a total of 17 doses. The solution should be diluted to a 5% concentration to improve palatability. If vomiting occurs within 1 hour of administration, the dose should be repeated. The standard intravenous NAC protocol begins with a 150 milligrams per kilogram loading dose up to a maximum of 15 grams, infused over 1 hour in 200 milliliters of 5% dextrose in water, D5W. This is followed by a second dose of 50 milligrams per kilogram up to 5 grams, diluted in 500 milliliters of D5W and infused over 4 hours. The final dose is 100 milligrams per kilogram up to 10 grams, diluted in 1,000 milliliters of D5W and infused over 16 hours. It is important to note that while many resources state a dosing of 50 milligrams per kilogram over 4 hours, this should be expressed as 12.5 milligrams per kilogram per hour for 4 hours. Misinterpretations, such as administering 50 milligrams per kilogram/hour for 4 hours, can lead to harmful errors. The volume of diluent varies for patients weighing less than 40 kilograms, but there are no official guidelines for patients exceeding 100 kilograms. The optimal duration of NAC treatment remains uncertain, and in many cases, more NAC is administered for a longer period than necessary. The traditional protocol, which involves 72 hours of oral NAC and 21 hours of intravenous NAC, was established based on estimations and safety considerations. In practice, shorter protocols are often utilized. If the acetaminophen concentration remains detectable at 10 mg/ml or 66 mol/L, or if transaminases continue to rise after completing the standard intravenous protocol, the third infusion is frequently extended beyond 16 hours. Some experts suggest that the NAC dose should be determined based on the body burden of acetaminophen and should be administered over a period of 5 half-lives for drug elimination. In practice, this sometimes means doubling the infusion rate of the third bag when acetaminophen levels are very high, although the definition of very high varies among clinicians. Several other factors are important to consider in NAC administration. For pregnant patients experiencing acute acetaminophen poisoning, intravenous NAC is preferred over oral administration because it ensures fetal exposure to the medication. When NAC therapy is interrupted, it is crucial to evaluate the remaining acetaminophen levels in the blood and assess the risk of hepatotoxicity. If more than 2 to 3 hours have passed since the interruption, it is recommended to restart the entire protocol, including the loading dose. Some guidelines suggest resuming treatment at the second dose instead. The standard European protocol for NAC administration, developed in the 1970s, has remained largely unchanged and is widely used for treating acetaminophen poisoning. It involves a loading dose of 150 milligrams per kilogram administered intravenously over 15 minutes, traditional, or 60 minutes modified, followed by a maintenance dose of 50 milligrams per kilogram intravenously over 4 hours, then 100 milligrams per kilogram over 16 hours. However, the complexity of this regimen has been linked to a high rate of medication errors. As a result, several alternative regimens have been developed and studied to improve safety, reduce treatment duration, and optimize resource use without compromising efficacy. One such alternative is the Scottish and Newcastle antiemetic pretreatment for acetaminophen poisoning (SNAP) regimen. This regimen delivers the same total dose of NAC 300 milligrams per kilogram as the European protocol, but over a shorter period of 12 hours instead of 20. It employs a lower initial infusion rate, which results in lower peak serum concentrations of acetylcysteine. This approach has been shown to significantly reduce adverse gastrointestinal effects and severe anaphylactoid reactions compared to the standard regimen. The SNAP regimen has been widely adopted in the United Kingdom, supported by robust studies. However, the initial research lacked blinding, potentially introducing observer bias or other limitations. The simplified 2-rate NAC regimen maintains the same total dose of 300 milligrams per kilogram as the European protocol. It differs by combining the first and second steps of the modified European protocol into a single infusion of 200 milligrams per kilogram administered over 4 hours. This adjustment results in a total treatment duration of 20 hours, similar to the European protocol. One of the main advantages of this regimen is its significant reduction in the incidence of NAC-related infusion reactions. It is also associated with a shorter duration of NAC administration and reduced hospital stays. However, a limitation noted is that one study employing this regimen had limited generalizability due to its focus on a predominantly young and female cohort. The North Carolina 2-rate regimen uses a loading dose of 150 milligrams per kilogram, similar to the European protocol. It differs in that it employs a continuous infusion at a rate of 15 milligrams per kilogram per hour for maintenance, rather than following the multi-step dosing schedule of the European protocol. This approach has demonstrated both safety and efficacy in routine clinical use and in high-risk patients. The loading dose administered over 4 to 9 hours aims to deliver the same total amount of N-acetylcysteine as the European protocol. This approach significantly extends the infusion time of the loading dose, depending on the time elapsed between ingestion and presentation. One advantage of this method is the reduction in infusion reactions, and it also shortens the overall course of treatment. However, its complexity may limit its feasibility outside specialized toxicology units. Key considerations include the potential for anaphylactoid reactions. Alternatively, regimens such as the simplified 2-rate protocol and the supervised N-acetylcysteine protocol are associated with a lower incidence of these rate-dependent reactions, likely because of their slower infusion rates and lower peak concentrations of N-acetylcysteine. Some alternative regimens, including the supervised N-acetylcysteine protocol and the 49-hour loading dose schedule, can shorten treatment durations compared to the standard European protocol. This can benefit both patients and healthcare resource management. Additionally, the complexity of the standard European protocol poses a higher risk of medication errors, whereas simpler protocols like the 2-rate regimen and the North Carolina protocol may help reduce this risk. The Scottish and Newcastle antiemetic pretreatment for acetaminophen poisoning regimen introduces a notable shift in the administration of N-acetylcysteine in cases of acetaminophen poisoning. It modifies the dosage and duration of the infusion, distinguishing itself from the traditional European protocol, which has been the standard of care for decades. Traditionally, the European protocol involves a loading dose of 150 milligrams per kilogram over either 15 or 60 minutes, followed by a multi-step maintenance dose infused over 20 hours. In contrast, The Scottish and Newcastle regimen administers N-acetylcysteine at 50 milligrams per kilogram per hour for the first 2 hours, then at 20 milligrams per kilogram per hour for the following 10 hours, resulting in a total infusion time of only 12 hours. One significant consequence of this slower and more extended infusion is a reduction in peak serum concentrations of acetylcysteine. This decrease is believed to be a key factor in mitigating anaphylactoid reactions, which are often rate-dependent. However, there is some question as to whether these assumptions are based on older, non-American dosage forms. Despite differences in infusion rate and duration, the total dose of N-acetylcysteine remains consistent at 300 milligrams per kilogram, ensuring that the regimen's effectiveness in preventing liver toxicity is preserved. The modifications in this protocol are rooted in a growing understanding of the nature of adverse reactions to N-acetylcysteine and its pharmacokinetics. Reactions that are not true allergies, but rate-dependent infusion reactions prompted the development of these new strategies. By employing a slower and more gradual infusion, the regimen aims to minimize sudden spikes in serum levels that are believed to trigger such reactions. Additionally, safety and patient comfort are primary considerations. Clinical trials investigating pretreatment with anti-nausea medications alongside the modified infusion have shown a significant reduction in gastrointestinal side effects and severe reactions. This evidence suggests that the revised approach enhances patient safety and comfort. Multiple studies support the efficacy and safety of this regimen. Trials have demonstrated a notable decrease in adverse reactions, with one large observational study finding an absolute risk reduction of 9% in infusion reactions. Despite its shorter duration and lower peak concentrations, the regimen has proven to be as effective as the traditional protocol in preventing liver toxicity. Consequently, it has gained widespread adoption in the United Kingdom, backed by robust evidence of its safety and efficacy. The duration of N-acetylcysteine treatment for acetaminophen overdose should not be determined by a fixed protocol length. Instead, it should depend on the patient's clinical condition and evidence of ongoing risk or toxicity. N-acetylcysteine should be initiated when a patient presents with a risk of liver toxicity as determined by a dosimetric nomogram, medical history, or clinical presentation. Continued administration of N-acetylcysteine is necessary for as long as the patient remains at risk or shows signs of liver toxicity. The treatment should be discontinued once the risk of toxicity has subsided and any existing liver injury appears to be resolving. Several factors need to be considered when deciding to stop N-acetylcysteine therapy. One criterion is the level of acetaminophen in the blood. Treatment should continue until the medication is fully metabolized, which is indicated by undetectable blood levels of acetaminophen. Improvements in liver function tests, such as aspartate aminotransferase levels, also guide treatment cessation. In patients without liver failure but with elevated liver enzyme levels, N-acetylcysteine should be continued until these levels decrease to less than 1,000 units per liter. There is no evidence of liver failure, and blood levels of acetaminophen are undetectable. In cases where liver failure is present, N-acetylcysteine should be continued until the prothrombin time or international normalized ratio indicates improvement. Specifically, when these measures are less than twice the normal value, encephalopathy has resolved if it was present, and acetaminophen levels are no longer detectable. Additional indicators for stopping treatment include improvements in coagulation parameters, with prothrombin time or international normalized ratio decreasing to less than twice the normal value, and the resolution of any mental status changes, such as encephalopathy. Clinical improvement, characterized by the resolution of symptoms and normalization of vital signs, should also be observed before discontinuing therapy. While many patients recover within the standard 21-hour intravenous protocol or the 72-hour oral protocol, some situations may necessitate extending N-acetylcysteine therapy beyond the initial treatment period. Such situations include elevated aspartate aminotransferase levels, with persistent levels exceeding 1,000 international units per liter. The continued presence of acetaminophen in the blood indicates incomplete metabolism and suggests an ongoing risk. Patients who develop hepatic failure require prolonged N-acetylcysteine administration until significant recovery of liver function is observed. Monitoring during N-acetylcysteine treatment is essential to guide decisions regarding treatment duration. Regular assessment of aspartate aminotransferase levels should be performed every 16 to 24 hours or more frequently if clinically indicated to evaluate the progression of liver injury. Additional liver function tests, such as prothrombin time, international normalized ratio, and creatinine levels, should be monitored every 24 hours or more often based on clinical judgment when aspartate aminotransferase levels are elevated. Serial measurements of acetaminophen levels can also aid in determining when the metabolism of acetaminophen has been completed. N-acetylcysteine is a well-established treatment for acetaminophen poisoning. When administered within 8 hours of ingestion, it effectively prevents liver damage by replenishing depleted glutathione stores, which are essential antioxidants for detoxifying the harmful metabolite N-acetylbenzoquinone imine. While the efficacy of N-acetylcysteine in acetaminophen toxicity is well documented, its effectiveness in treating other toxicities and illnesses remains less clear. Research on its use for conditions such as septic shock, coronary artery disease, and acute liver failure unrelated to acetaminophen has produced mixed results. There is some evidence supporting the use of N-acetylcysteine in cases of poisoning caused by mushrooms containing cyclopeptides. In particular, it is recommended for poisoning by the death cap mushroom Amanita phalloides. The rationale for this recommendation stems from the similarity between amatoxins found in these mushrooms and acetaminophen toxicity. Additionally, N-acetylcysteine has been considered for treating poisoning from carbon tetrachloride, pennyroyal oil, and hepatotoxicity induced by chronic valproate use. The common understanding is that these toxins also deplete glutathione, leading to liver damage. Research has also explored the potential of N-acetylcysteine to reduce nephrotoxicity caused by the chemotherapy drug cisplatin, to increase the excretion of certain metals, and to improve outcomes in cases of fulminant liver failure regardless of the cause. Its potential to prevent contrast-induced nephropathy has been studied, but results have been mixed. Ongoing research focuses on developing more specific markers for detecting evolving toxicity, optimizing dosage, and determining the appropriate duration of treatment. The ultimate aim is to tailor N-acetylcysteine therapy to individual patients based on factors such as the concentration of acetaminophen in their system and the time elapsed since ingestion. Fomepizole, primarily known as an alcohol dehydrogenase inhibitor, is increasingly recognized as a potential treatment for acetaminophen poisoning due to its ability to inhibit the enzyme cytochrome P452 times 10 to the power of 1. This enzyme is responsible for converting acetaminophen into the toxic metabolite N-acetylbenzoquinone imine. A dose of 15 milligrams per kilogram administered intravenously can achieve serum concentrations nearly 3 times higher than the level required for maximum inhibition of cytochrome P452 times 10 to the power of 1 in humans. Several factors make fomepizole an attractive option for treating acetaminophen poisoning. Many clinicians are already familiar with this medication, which has an excellent safety profile. Its dosing regimen is straightforward and does not require special monitoring. Additionally, fomepizole demonstrates predictable efficacy in inhibiting the enzyme responsible for producing the toxic metabolite, supporting its potential utility in managing acetaminophen overdose. The use of fomepizole for treating acetaminophen poisoning is relatively recent, but research and case studies indicate its potential benefits. Early studies in the 1990s using mice demonstrated that fomepizole effectively prevented the production of a toxic metabolite called NAPK and reduced liver cell death in rats. A notable case report from 2013 described a patient with severe acetaminophen overdose who received fomepizole and survived despite a poor initial prognosis. This suggests that fomepizole may help prevent NAPK formation in humans. Further analysis of data from the treatment and outcomes of intoxication cases database showed that even though many patients who received fomepizole exhibited signs of severe poisoning, indicated by high scores on the King's College criteria, their mortality rate was relatively low at 24%. Recent case series involving 16 patients with severe acetaminophen poisoning, including some with very high levels of the drug in their blood, reported a 100% survival rate after treatment with fomepizole. Importantly, no adverse effects from the drug were observed in these cases. Despite these promising initial findings, several considerations remain. Availability and cost pose barriers. Fomepizole may not be accessible in all healthcare settings, and its expense could limit widespread use, especially given the frequency of acetaminophen overdose cases. Further research is essential to establish fomepizole's definitive role in treatment protocols. This should include more extensive studies to determine optimal dosing strategies and to compare its effectiveness against standard treatments such as N-acetylcysteine. In summary, fomepizole appears to be a potentially valuable addition to the options for treating acetaminophen poisoning, particularly in cases of large overdose or delayed treatment. Continued clinical research and experience will be crucial in defining its exact role and establishing clear guidelines for its use. While N-acetylcysteine is the primary antidote for acetaminophen toxicity, several additional strategies exist to enhance the elimination of the drug or to mitigate damage caused by the toxic metabolite NAPK. It is important to note that many of these approaches are either briefly mentioned, investigated in experimental settings, or remain in the early stages of research. To accelerate the removal of acetaminophen from the body, especially when standard N-acetylcysteine therapy might be insufficient or rapid detoxification is necessary, several techniques are employed. One such method is hemodialysis, which can effectively clear acetaminophen and N-acetylcysteine from the circulation. Most toxicologists recommend considering hemodialysis in patients with exceedingly high serum acetaminophen concentrations who remain at high risk of liver damage despite receiving N-acetylcysteine treatment, and in individuals presenting with severe metabolic acidosis and elevated lactate levels. Another approach is the molecular adsorbent recirculating system, an extracorporeal liver support system that can assist in removing acetaminophen and other toxins associated with liver failure. While promising, more research is necessary to determine its utility, specifically in cases of acetaminophen toxicity. Single-pass albumin dialysis, similar to the molecular adsorbent recirculating system, uses albumin to bind and remove toxins from the blood. However, the effectiveness of this method in treating acetaminophen poisoning remains unclear. Certain clinical situations may benefit from these enhanced elimination techniques. Early after an overdose, if serum acetaminophen levels are excessively high despite treatment with N-acetylcysteine, or if there is evidence of metabolic acidosis and elevated lactate, these methods may be considered. Later in the course of toxicity, these techniques can also be useful in preparing for liver transplantation by removing remaining acetaminophen before the procedure or in removing toxins associated with hepatic failure. Several experimental approaches to treating acetaminophen toxicity have been proposed, although their application in clinical practice remains speculative. One such approach is hyperbaric oxygen therapy. Animal studies indicate that hyperbaric oxygen can reduce the toxicity of acetaminophen, potentially by increasing oxygen delivery and alleviating oxidative stress. However, there are no human trials to support this. Research also explores targeting specific molecular pathways involved in cell death following the formation of a toxic metabolite. These include investigating the role of mitochondrial permeability transition pores, mitogen-activated protein kinases, such as C-Jun and terminal kinases, mixed lineage kinase 3, and apoptosis signal-regulating kinase 1, as well as inflammatory mediators. Additionally, microRNAs like microRNA 122 are being studied as biomarkers for early detection of liver injury and as potential therapeutic targets to modulate cellular responses to toxicity. Supportive care remains vital in managing acetaminophen toxicity. This involves addressing complications and supporting organ function regardless of the specific antidote used. Monitoring and treating metabolic disturbances such as hypoglycemia, metabolic acidosis, and electrolyte imbalances are essential. To manage coagulopathy, vitamin K can be administered to improve clotting factor synthesis. In cases of significant liver damage, the use of fresh frozen plasma or prothrombin complex concentrates should be guided by bleeding risk rather than solely by laboratory measurements such as prothrombin time or international normalized ratio. Cerebral edema is a serious complication that may require interventions such as hypertonic saline, elevated head positioning, and measures to ensure adequate cerebral perfusion pressure. N-acetylcysteine, the established antidote, also helps preserve cerebral blood flow in this setting. It is important to note that the efficacy and safety of many of these alternative treatments need further evaluation before they can be recommended for routine clinical use. While exploring additional therapies is valuable, N-acetylcysteine remains the gold standard treatment for acetaminophen toxicity, especially when administered early. Any supplementary therapies should be considered carefully based on the patient's clinical status, the severity of the toxicity, and available resources. A comprehensive approach that combines proven antidotal therapy with supportive care and ongoing research into novel treatments offers the best strategy for improving outcomes in acetaminophen toxicity. Acetaminophen's journey to acceptance began with its synthesis in 1878, but widespread adoption was delayed until the 1970s due to concerns about toxicity associated with its predecessors, phenacetin and acetanilide. Once it was deemed safe at appropriate doses, its popularity surged. However, its availability without a prescription has led to frequent misuse and overdoses, contributing significantly to cases of acute liver failure. The liver metabolizes acetaminophen through three main pathways: glucuronidation, sulfation, and oxidation via the cytochrome P450 enzyme system. The oxidation pathway, primarily involving the enzyme CYP2E1, produces a toxic metabolite called N-acetyl-P-benzoquinoamine. Under therapeutic conditions, most acetaminophen is processed safely through glucuronidation and sulfation, and the small amount of the toxic metabolite produced is effectively neutralized by glutathione. Several factors can increase the production of this toxic metabolite or impair the body's ability to detoxify it. Substances such as ethanol, rifampicin, isoniazid, and carbamazepine can induce the enzyme CYP2E1, leading to higher levels of toxic metabolite generation. Conditions like malnutrition and chronic alcohol abuse deplete glutathione stores, making the body more vulnerable to acetaminophen toxicity. Additionally, co-ingestion of opiates can worsen the toxic effects. Determining a toxic dose of acetaminophen is complex due to individual differences and various influencing factors. It is important to consider circumstances that can render its use harmful, such as overdose or interactions that enhance toxicity. Diagnosing toxicity from acetaminophen depends largely on the nature of exposure. In cases of acute overdose, a detailed history is essential, and serum acetaminophen levels should be measured at least 4 hours after ingestion. These levels are then plotted on the Rumack-Matthew nomogram. Concentrations above the treatment line indicate a high risk of liver damage, warranting treatment with N-acetylcysteine. In instances of repeated supratherapeutic ingestion, diagnosis becomes more challenging because the nomogram does not apply. Healthcare providers must assess for signs of liver damage, evaluate dosage history and risk factors, and conduct laboratory tests such as serum acetaminophen concentration and liver enzyme levels. Current diagnostic tools have limitations. The Rumack-Matthew nomogram is designed for single, acute ingestions and may not be accurate for extended-release formulations, intravenous administration, or chronic overdoses. Relying solely on liver enzyme levels like aspartate aminotransferase may not be sensitive enough to detect early liver injury in chronic cases. The nomogram itself is a visual tool used to gauge the risk of liver toxicity after an acute ingestion by plotting serum acetaminophen concentration against time since ingestion. The treatment line, often called the 150 line, marks the threshold beyond which liver damage is likely indicating the need for antidotal therapy with N-acetylcysteine if the patient's levels exceed this line. Several factors can influence the accuracy and applicability of this method. These include the accuracy of the ingestion history, as precise timing is crucial, and the use of extended-release formulations which can cause delayed absorption and false interpretation of the serum levels. Intravenous acetaminophen overdose is not well validated with this tool, and in cases of massive overdose, there are additional considerations. While there is no universally accepted definition of a massive overdose, additional criteria such as high total ingested amount, elevated serum concentrations shortly after ingestion, and weight-based calculations are used to distinguish severe cases. Managing these overdoses is complicated by altered pharmacokinetics and potential extrahepatic toxicities like kidney injury and metabolic acidosis. Uncertainties regarding optimal doses and timing of the antidote complicate treatment. A useful predictive tool, the acetaminophen and aminotransferase multiplication product, involves multiplying the initial serum acetaminophen concentration by the peak liver enzyme level within 24 hours. If this product exceeds 10,000 units, there is a high likelihood of significant liver injury. This method offers early assessment and is applicable in various scenarios, but it has limitations, including reduced usefulness beyond 24 hours after ingestion, and should not replace clinical judgment. Interestingly, the tendency for allergic reactions to N-acetylcysteine decreases as serum acetaminophen concentrations increase, supporting the use of modified administration protocols such as the SNAP regimen, which aims to minimize reaction risks. Guiding decisions about liver transplantation involve using criteria like the King's College criteria, which include specific clinical and laboratory parameters to evaluate the prognosis of fulminant hepatic failure caused by acetaminophen poisoning. N-acetylcysteine remains the cornerstone of treatment, functioning by preventing the formation of toxic metabolites, enhancing their detoxification by serving as a precursor to glutathione, and protecting multiple organs in cases of severe liver failure. It can be administered orally or intravenously, with intravenous delivery preferred in cases of fulminant hepatic failure, intolerance to oral therapy, or during pregnancy. Various treatment regimens with N-acetylcysteine have been studied beyond the standard protocol. The SNAP regimen delivers the same total dose over a shorter period, reducing peak serum concentrations and minimizing adverse effects. Other approaches include simplified two-rate regimens that shorten treatment duration and continuous infusion protocols, which aim to improve safety and efficacy, especially in high-risk groups. Extending the initial infusion over 4 to 9 hours may decrease reactions, but increases complexity. The timing of administration is critical. The efficacy of N-acetylcysteine diminishes after 8 hours from ingestion, though it may still confer some benefit. Both oral and intravenous routes are effective when started early. Oral therapy is more accessible but has a higher risk of causing vomiting, whereas intravenous therapy ensures reliable dosing but can trigger allergic-like reactions. Emerging adjunct treatments, such as fomepizole, a CYP2E1 inhibitor, show promise in preventing the formation of the toxic metabolite, especially in cases of massive overdose or delayed presentation. Nevertheless, issues like availability, cost, and the need for further research limit its current use. Treating acetaminophen toxicity requires a comprehensive approach that incorporates understanding the complexities of the drug, individual patient factors, and ongoing advances in medical practice. Early detection, prompt administration of N-acetylcysteine, careful monitoring, and supportive care are essential to achieve optimal outcomes. Moving beyond fixed-duration protocols and adopting personalized treatment strategies guided by continuous assessment of clinical and laboratory parameters are vital for safe and effective care.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have. and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.